Welcome to Innovation Center's three-part video series on value-based healthcare, what every clinician should know. Payment impacts the kind of care clinicians provide. These videos will take the viewer from the current state of fee-for-service to assuming both up and downside risk in value-based care, and will tell you what you need to know to be successful. This shift from fee-for-service to value-based care means that you can take care of patients the way you were trained to do. For more on how to obtain CME or CEU credit and for important supplementary materials, please see the video description included with this video.
Hi, my name is Dr. Michael Lipp, Chief Medical Officer at the CMS Innovation Center, otherwise known as CMMI. Prior to joining CMMI, I both practiced and held leadership roles with medical groups that take full financial risk for their patients. During my career, I've had the pleasure of working with Dr. Chen, CEO of ChenMed. Soon, Chris will join me in a conversation about what it means to take on full accountability, which includes both upside and downside risk. He will describe how this type of arrangement can benefit both your patients and your practice. At the conclusion of the CME activity, you should be able to define capitation and discuss the benefits of participating in an advanced APM, describe what steps clinicians need to take to move towards two-sided risk, identify what models are available to clinicians who want to assume two-sided risk, and finally, recognize the key drivers for success in these models. Before you embark on this journey, it's important that you assemble the necessary resources. First, it starts with a commitment to change and innovate at all levels of your organization, from leadership to frontline clinicians, from staff to partnering practices. Success in two-sided risk relies heavily on having actionable patient data, so it's important to have data systems that will allow patient tracking and risk stratification. Clinical protocols should be in place to support standardized care pathways and facilitate team-based coordinated care. Organizations must know their legal and financial requirements, which may include having adequate capital reserves. Finally, successful organizations should be able to manage utilization to ensure that patients are receiving the right care in the right setting at the right time. Health plans often have multiple levers to manage utilization, such as deductibles or select networks. However, practices may not have all of these tools available to them. The levers available to a practice to manage utilization may differ depending on the type of risk arrangement. Now, I want you to hear from one clinician who is participating in the Maryland Total Cost of Care model and has experienced both the benefits and the challenges of two-sided risk.
My name is Dr. Stacy Garrett-Ray. I'm from the University of Maryland Quality Care Network, as well as Transform Health MD. I am the president of those two organizations, which actually help to provide wraparound resources for providers who are interested in being in value-based contracts. If you're going to go into any type of upside or even downside risk, how much you're able to manage in terms of some of the cost, if you have any type of reserves, because it usually is going to take a period of time to get to the point where you actually see any type of revenue. So you need to make sure that you're actually prepared from that standpoint. So I would actually say that one of the challenges, but also one of the blessings in actually having partners who are not all within the same system, is that you actually build a network. You actually build additional resources. You start leveraging promising or best practices at other organizations when you come together. You look at what's worked at one, what hasn't worked at the other. You also have the opportunity to say, how can those providers who actually are surrounding my hospital, or hospitals in our case, how can we partner together to manage total cost of care? The majority of our patients are actually not stepping foot in a hospital. They're spending the majority of their time in an ambulatory setting. And so who are they going to? They're going to their primary care providers. They're going to people like me in Maryland who see patients, or they're going to any of the other PCPs that we see there. So you need to know what are the resources. We've focused also on communications. We've worked on having our physician liaisons be engaged with the practices and providers that we work with so that they're also aware of other resources that are available. For our team, one of the opportunities, one of the benefits, but also one of the challenges is that I work with close to 400 primary care providers throughout the state. And we've got multiple EMRs, multiple employers. Not all of them actually work for our organization. In fact, the majority don't. About 75% of them do not work for the University of Maryland. And you've got to be able to figure out how to engage them all. And that is a challenge because you're working on different levels all the time. You're working from the leadership level, the leadership buy-in that's necessary, then going to each site, making sure that they're medical directors and champions that actually understand and engage and will monitor and support. And then the providers themselves to be able to say, okay, so why am I doing this? And one of the things that I think we have learned over the years is if you don't articulate the why, but if you don't help people to understand the why in everything that they're doing, then they're going to not do it. That's the reality. Having data available to you is probably one of the most important steps that you can even have when you're looking at any type of value-based model. So the way that I really think about even population health management, which is really what we do, it's that you have to be able to know, engage, and manage your population. And so having analytics to actually help you, data to let you know who are those patients, what are some of those conditions, geographically, where are they located, and where do I need to provide my resources? What am I actually seeing in terms of some of the claims that are coming through? Can I use some predictive analytics to actually help me to actually know and be able to risk stratify my population? Because at the end of the day, I think of it this way: if you have 100,000 patients and you're trying to figure out where do I actually allow my resources to go to make a difference, it's not going to be 100,000. You're actually going to be looking at a smaller population, and you've got to be very smart and resourceful to be able to do so. So your data is actually going to be your best friend.
Thank you for sharing that perspective. Dr. Garrett Ray highlighted some of the important factors that go into assuming full risk, including some of the challenges when becoming accountable for downside risk. Providers that enter into these arrangements need to have strategies to mitigate the challenges. Some of the challenges include the need to manage acute utilization, recognize and respond to social determinants of health, capture and document patient acuity, and prepare for potential financial uncertainty when being held accountable for downside risk. Some mitigation strategies include, first and foremost, knowing your patients. You should know when medical interventions are appropriate and know if these interventions should be done in the office or in the home. It will be important to routinely screen your patients, which could include assessments for social determinants of health for things like food insecurity or medical transportation needs. Data is incredibly important when assuming two-sided risk. It is important to ensure that you have accurate data about the diseases and treatments that are being given to your patients. Finally, some of the uncertainty that can occur when assuming full risk can be mitigated by having adequate capital reserves, as well as good data management systems. Now let's hear more about how providers can benefit when they assume full risk. I'm delighted to introduce Dr. Christopher Chen from ChenMed, who is widely known for his expertise in managing populations with full accountability. Chris, can you start off by telling us a little bit about what capitation means?
What capitation allows you to do is, instead of having a fractionated system where you have one doctor getting paid for one thing here, if you have your pinky worked on, that's one doctor. If you have your kidneys worked on, that's a different doctor. And a lot of times they don't talk. And I think to myself, in the human body, all those things, they work together and they interact. So what capitation does is it says, hey, instead of just putting this into piecemeal and playing doctors individually for their individual part, why don't we allow doctors the freedom to be able to explore and coordinate and create overarching plans for these patients to deliver a superior outcome. So here's how it works. What typically happens is you are given a lump sum of dollars to be accountable for. And with that lump sum of dollars that you're accountable for, what comes along with that is the responsibility of caring not only for your portion, but also to help the patient navigate through all the other portions of healthcare as well. And then you also have the responsibility to have that care coordinated at one place. So that way you have a leader, a quarterback, if you will, that can help to take care of that entire patient. And so as those dollars are flowing in, what that also gives you is the opportunity to create tremendous innovation. So what capitation does financially is to say, hey doctor, we want you to win. We want you to win personally. We want you to feel a great sense of purpose. We want you to rejoice, and we want you to win also financially when patients win, not the other way around. And that's a huge fundamental shift. But here, it doesn't just stop there, because that shift creates great job satisfaction. The amount of purpose that you gain when you know that you have the resources, that you have the financial control, that you have the flexibility to do the right thing for the patient is very fulfilling. See, as a primary care physician, you know for a fact that actually what we learned in medical school and what we learned in training only comprises the minority of a patient's health. You know that pills, procedures, and referrals really can only make so much of a difference. If you're really going after patient health, there are these other things that we have to be accountable for. So for example, social determinants. These are things that really can impact health. If you're worried about your son stealing your Social Security check and you're in poverty, that will affect your health. If you are living in Philadelphia, like some of our patients do, and your heat gets turned off because you cannot afford heat, that will affect your health. There are all of these challenges that will affect your health. And we, if we're in charge of the overall health of the patient, we have to address it.
Chris, can you tell us a little bit about how data influences care in a full risk environment?
Now, the challenge that we have today is that most systems and technology today is designed for fee-for-service. They're designed to help facilitate a fee-for-service workflow for doctors. What we've discovered is that because the workflows, when you're in a full risk or capitated environment where the primary care doctor is accountable for the overall health of the patient, the workflows are not just a little bit different than fee-for-service. They're actually, in many cases, completely the opposite. And so in that case, since the workflows are so vastly different, you need technology that's going to actually not be slightly different than a fee-for-service piece of technology, but actually be fundamentally different. And so what I would encourage folks to do is to really take a hard look at the existing workflows and the technology that they have today and their ability to get data at the point of care today with a very different goal in mind, moving from transactions to actually trying to deliver total health.
So Chris, as you may know, the CMMI Innovation Center has announced models to meet providers where they are. And that includes small practices that want to take on accountability, including practices that want to manage patients with serious illness. In addition, we have models for organizations that want to take on full risk through direct contracting model.
A lot of people have looked at practices like ours as, oh, that's innovative and that's boutique, but we don't really know if that's here to stay. Is actually looking after the patient's total health and a fully capitated arrangement. Is that something that is an experiment, or is that something where people want to go? And so there's a tremendous amount of uncertainty involving this. So doctors are practicing both, let's call it fee-for-service and transactional medicine, and then perhaps dabbling a little bit in the kind of care that we're talking about. This move by CMMI is bold because it basically sends a message that healthcare is going to move in this direction. That healthcare is going to move in a direction in which that they're going to expect primary care to lead, they're going to expect those same primary care doctors to be accountable for the full well-being of the patient, and that those doctors will win when patients win. And that is a needed message.
Chris, can you tell us a little bit about specialists and how the opportunities exist for them within value-based care to coordinate with primary care providers?
You know, specialists are critical. We cannot deliver superior health for the patient without great specialty care. The biggest shift for specialists is they go from practicing in a silo to actually practicing on a team. And a lot of specialists find that tremendously rewarding, to actually be a part of a team, a winning team, that where they can see great outcomes through their patients. Specialists have the opportunity to practice much more holistically, and a procedure is just one part of the repertoire of what they've been trying to do. And so what we found is specialists have the opportunity to really have a voice much earlier on in the patient's overall care in these type of environments. And what that allows the specialist to do is offer things that perhaps could prevent the stent, could prevent the spine surgery, and actually get involved in the total health continuum of that patient.
In prior videos, we've talked about alternative payment models, or APMs. But Chris, what you've talked about sounds more like an advanced APM. Can you talk a little bit about that?
Well, you know, the advanced APM, what that means is that not only is there an opportunity to win when patients do well, but there's also this concept of downside risk. You know, it's really interesting. A lot of folks focus on the downside. Anytime I enter a new city or opening another practice, I'm actually not thinking as much about the downside. I'm actually thinking more about the upside. And in fact, I'm always looking for arrangements in which I don't have a limited upside. And if that requires me to take downside, it doesn't even come into my mind. And the reason is because I want to be able to capture the full upside potential of that patient, both from a health perspective, but also from a financial perspective. Because I know for a fact, and I've seen this time and time again, the formula is there. If you have a group of clinicians who have absolutely made the decision that they want to be accountable for the total care of the patient, and they have the right data and they have the right team together, the opportunity is tremendous. And so, you know, as a physician, but also somebody who runs a practice, my number one concern, at least financially, is how do I make sure that I capture all of the upside? What we typically tell our physicians and our primary care doctors is, number one, you know, we believe that fee-for-service is on its way out, and that the entire country is moving towards a value-based environment where doctors are expected to take downside risk. The second thing that we've also told our doctors is, don't be afraid of the downside risk. The upside opportunity is great, is demonstrated, and is proven. And so if you go in all in, and you can get your team there as well, your team being the people that you selected to be around you to help you accomplish these goals, your likelihood of success is extraordinarily high.
So Chris, I want to say thank you for talking with us. It's been a really great conversation. Just wondering if you have any parting thoughts for providers that are watching this video.
You know, this is a great time to be a doctor. This shift really allows for two major things. It allows for clinicians to find tremendous fulfilling purpose because they get to drive towards better health for their patients. And that's exactly the reason why they went to medical school. And they have the freedom and the responsibility, but also the privilege of being able to do so outside of a transactional environment. It's actually quite liberating. The second thing is, this also allows there to be great opportunity for personal growth and personal gain. This is an opportunity where when patients win, because we can allow them to win, and we work together to allow them to win and deliver better health or achieve better health, that we as clinicians can substantially financially benefit from driving that better health. You know, in the past, it's not always the case, and it hasn't been the case. But as a group of physicians who actually went into this profession to drive better health, we finally have the opportunity and the freedom and the reward of being able to achieve that better health.
Thank you. We discussed with Chris some of the models CMMI has created for clinicians, but let me give you more details. These include different options for clinicians that want different levels of risk. One option is a Bundled Payments for Care Improvement Advanced, otherwise known as BPCI Advanced. This model offers voluntary episode payment models around clinical episodes. The model aims to support healthcare providers who invest in practice innovation and care redesign to better coordinate care, improve quality, and reduce expenditures. As I mentioned with Chris, another option is Primary Care First, which offers an innovative payment structure to support delivery of advanced primary care. It's based on the underlying principles of the existing Comprehensive Primary Care Plus model, also known as CPC Plus. This includes prioritizing the doctor-patient relationship, enhancing care for patients with complex chronic needs and patients with serious illness, reducing administrative burden, and focusing financial rewards on improved health outcomes. The final option we will review is direct contracting, which allows sophisticated organizations to take full accountability for their patients at a local level. This model aims to transform risk-sharing arrangements in Medicare fee-for-service by offering both capitated and partially capitated population-based payments that move away from traditional fee-for-service. We want to thank Chris for shining a spotlight on what it means to manage financial risk in a value-based payment model, as well as help us understand what physicians need to know to succeed in these models. For many clinicians, like me, it can make practicing medicine more rewarding by aligning incentives between patients and providers. However, taking full accountability requires commitment. This includes commitment from all staff members, clinicians, even leadership. Everyone must be prepared to change behaviors, workflows, and priorities to realign healthcare to a value-based system of care. Now that you are equipped with the knowledge you need to explore new value-based payment options, you can do what you went to school for: take great care of patients.